Bipolar disorder is a complex neuropsychiatric condition affecting millions globally, characterized by extreme mood swings between mania or hypomania and profound depression. It is far more than simple mood swings. It involves deep neurological changes that impact perception, energy, judgment, and behavior in ways often beyond conscious control. Approximately 2 to 3% of the world's population live with some form of bipolar disorder, making it one of the most common and debilitating psychiatric illnesses. The average age of onset is 18, though it can manifest at any age from childhood to late adulthood. There are 3 main types clinically recognized. Bipolar I disorder features at least one full manic episode, often accompanied by major depressive episodes. Mania in bipolar I is severe. It may include psychosis, complete loss of touch with reality, and dangerously impulsive behaviors, frequently requiring hospitalization. During manic episodes, individuals may believe they have special powers, feel persecuted, or identify as historical figures. About 35% of suicides among bipolar patients happen during or immediately after manic episodes, when judgment is gravely impaired. Bipolar II disorder involves episodes of hypomania, a less severe form of mania, alternating with major depressive episodes. Hypomania may actually appear productive. Heightened energy, reduced need for sleep, bursts of creativity, and increased sociability. Many bipolar II patients report feeling finally normal or better than ever during hypomanic states. Yet this deceptive productivity conceals real risks. Poor judgment, impulsive decisions, excessive spending, risky sexual behavior, and often a devastating depressive episode follows. Depression in bipolar II can be as severe as bipolar I, with significant suicide risk. Cyclothymia is considered a milder form, characterized by chronic fluctuations between hypomanic symptoms and depressive symptoms that do not meet full criteria for major episodes. Symptoms persist for at least 2 years in adults, with the person rarely symptom-free for more than 2 consecutive months. Though less intense than bipolar I or II, cyclothymia profoundly affects quality of life and carries risk. Studies show 30% of cyclothymic individuals progress to bipolar II, and 1 to 5% progress to bipolar I. Manic episodes feature symptoms such as boundless energy, an almost absent need for sleep, sleeping only 2 to 3 hours per night without fatigue, racing thoughts bouncing uncontrollably from one topic to another, pressured speech where the person talks rapidly without pause, extreme impulsivity, including disastrous financial decisions, risky sexual behavior, reckless driving, grandiosity where they genuinely believe in their special powers, severe irritability that can turn into aggression, and in severe cases, psychotic symptoms such as paranoid delusions or auditory hallucinations. Individuals in mania often lack awareness of their condition, convinced they are at their best while their behavior destroys their lives. Depressive episodes involve persistent deep sadness, overwhelming hopelessness, complete loss of interest or pleasure in activities, extreme fatigue where even small tasks feel impossible, significant changes in appetite and weight, either overeating or almost none, severe insomnia or hypersomnia, sleeping up to 14 to 16 hours daily, cognitive impairment, including difficulty concentrating, memory lapses, poor decision-making, intense feelings of guilt or worthlessness, psychomotor agitation or retardation, and recurrent thoughts of death or suicide. Bipolar depression is especially dangerous, often less responsive to standard antidepressants and linked to very high suicide risk. Mixed episodes represent one of the most dangerous states when manic and depressive symptoms occur simultaneously. Imagine frenetic energy, racing thoughts, and impulsivity combined with profound despair and suicidal ideation. This deadly mix creates a high risk as the person has the drive and energy to act on suicidal thoughts. Suicide risk during mixed states is up to 5 times higher than in depression alone. The exact causes of bipolar disorder remain partially unknown, but research points to a complex combination of genetic, neurobiological, and environmental factors. Heredity plays a crucial role. If one parent has bipolar disorder, offspring's risk rises to 10 to 25%. If both parents have it, risk jumps to 50 to 75%. Studies of identical twins reveal concordance rates between 40 and 70%, confirming strong genetic influence. Neurobiological alterations include dysregulation of neurotransmitters, serotonin, norepinephrine, and dopamine, that regulate mood, energy, and motivation. Brain imaging shows structural and functional differences in the amygdala, prefrontal cortex, and hippocampus in bipolar individuals. Environmental factors that trigger episode onset or relapse include severe stress like trauma, bereavement, job loss, or divorce, chronic sleep deprivation disrupting circadian rhythms, substance abuse such as alcohol, marijuana, cocaine, and amphetamines, medications like corticosteroids or antidepressants used alone without mood stabilizers, which can provoke mania, and hormonal dysfunction, especially thyroid disease. Postpartum period represents a vulnerable time for women prone to bipolar disorder. Several dangerous myths perpetuate stigma and hinder treatment. Myth 1: bipolar disorder is just exaggerated normal mood swings. Reality: bipolar episodes last days, weeks, or months, not normal hourly mood fluctuations. Myth 2: bipolar people are violent. Reality: most are not violent and often victims rather than perpetrators. Myth 3: you can't have a normal life with bipolar disorder. Reality: with proper treatment, many live productive, fulfilling lives. And myth 4: medication cures bipolar. Reality: no cure exists, but treatment controls symptoms and prevents relapse. Proper diagnosis often takes years. Studies show patients consult 3 to 4 professionals on average, and diagnosis takes 6 to 10 years after first symptoms. Reasons include symptom overlap with unipolar depression, anxiety, ADHD, and personality disorders. Patients may not report hypomanic episodes because they feel good, and insufficient clinician training leads to misdiagnosis. Bipolar II is especially prone to misdiagnosis as depression predominates. Treatment requires a multifaceted approach combining medication, psychotherapy, and lifestyle changes. Mood stabilizers are the cornerstone. Lithium remains gold standard, showing efficacy in 60 to 70% of cases and unique anti-suicide properties. Anticonvulsants like valproate, lamotrigine, and carbamazepine are effective alternatives. Atypical antipsychotics like quetiapine, olanzapine, and aripiprazole assist especially during mania or mixed episodes. Antidepressants must be used cautiously, always alongside mood stabilizers, as mono use can provoke mania.
Psychotherapy is essential yet often neglected. Specialized cognitive behavioral therapy teaches early recognition of episodes, coping skills, reframing distorted thoughts during episodes, and maintaining routines to stabilize mood. Psychoeducation, teaching patients and families about the disorder, medication adherence, and relapse warning signs, reduces relapse rates by up to 40%. Interpersonal and social rhythm therapy focuses on regulating daily routines, especially sleep and social activities. Recognizing circadian disruptions trigger episodes. Family therapy improves communication, reduces guilt, and enhances support during crises. Lifestyle changes complement medical and psychological treatment. Strict sleep hygiene, consistent sleep-wake times, avoid stimulants after midday, create dark and quiet sleep environment. Regular physical exercise shows mood stabilization comparable to medications. Avoid alcohol and drugs as they destabilize mood, interfere with treatment, and elevate episode risk. Stress reduction via mindfulness, yoga, or relaxation techniques aids prevention. Keeping mood charts, logging daily symptoms, sleep, and stressors helps early detection. Social support is often decisive between stability and relapse. Support groups connect sufferers, sharing challenges, reducing isolation, and exchanging coping. Educated families, friends detect subtle early signs clients miss, intervening before episodes escalate. Compassionate employers allowing flexibility improve employment retention, crucial for self-worth and stability. Prognosis varies. With proper treatment and consistent adherence, 50 to 60% achieve significant stability and functional success. Yet 40% endure chronic residual symptoms even when treated. Factors improving outcomes include early diagnosis, aggressive initial treatment, strong support, medication adherence, absence of comorbidities like substance abuse, and prior high function. Poor outcomes linked to early adolescent onset, frequent mixed episodes, rapid cycling with multiple episodes yearly, comorbid anxiety or ADHD, and previous suicide attempts. Bipolar disorder impacts beyond the individual. Families endure emotional stress caring for loved ones in crises, facing guilt, frustration, and exhaustion. Romantic relationships are vulnerable, divorce rates 2 to 3 times higher than general population. Children of bipolar parents face genetic risk plus emotional challenges witnessing episodes. Economic cost is immense. Lost productivity, frequent hospitalizations, expensive medications, and unstable employment burden families and societies. If the scientific secrets of bipolar disorder fascinate you, subscribe now for more deep dives into psychology, mental health, and neuroscience that can transform how you understand the mind. Do you know someone with bipolar or suspect symptoms in yourself? Share in the comments. Your story can help. Share this video with those who need to understand this condition. Awareness saves lives. We have unveiled bipolar disorder, from definitions and types through detailed symptoms of mania, hypomania, and depression, genetic and neurobiological causes, harmful myths, complex diagnosis, evidence-based treatments, and lifestyle strategies. Bipolar disorder is not a character flaw, exaggerated drama, or moral failing. It is a real neurological condition requiring medical treatment, social understanding, and human compassion. If you feel like a fraud in depressive episodes or invincible in mania, remember, these are neurobiological dysregulations, not true reflections of yourself. With proper care, consistent support, and disciplined self-management, a meaningful and dignified life is possible. The journey is hard, but you are not alone. Millions face the same battle daily, proving that recovery and stability are achievable. Your mind may be a roller coaster, but you can learn to hold the tracks.